All right, we're live. Hello, everyone. I'm Nicholas Chan, reporter with Being Patient, and welcome to our live talk series today on delirium, brain dysfunction, and dementia in ICU survivors. And today we'll be talking to Dr. Wesley Ely, professor of medicine and critical care at Vanderbilt University Medical Center and author of the new book, Every Deep Drawn Breath, a critical care doctor on healing, recovery, and transforming medicine in the ICU. Dr. Ely, thanks for joining us today.
Thank you so much. I appreciate being here, and I hope that the listeners find the bravery of these patients they're going to meet today something inspiring.
Right, and Dr. Ely, I want to start off with a story of one of your patients that you talked about in the beginning of the book, and that's the story of Teresa Martin. She was a patient of yours when you were still a resident in training. And she was admitted to the hospital after an attempted suicide from taking a handful of pills. And she was kept on life support. She was heavily sedated. She survived and recovered at the hospital. But when she returned to the hospital for a follow-up appointment, it wasn't the triumphant reunion that you had imagined, and her mom was saying that her brain just wasn't functioning properly. Can you tell us more about this experience for you as a young doctor? What was that like for you, and how later on you actually realized that many ICU patients, just like Teresa, suffered from disabling symptoms after being discharged from the ICU in the hospital?
Absolutely, Nicholas. I'm really glad you chose to start with Teresa. She's, at the beginning of Every Deep Drawn Breath, and I'm going to hold this book up for the audience. This is the title of the book, Every Deep Drawn Breath, which comes from John Steinbeck's East of Eden. It's one of the most beautiful pieces of prose ever written, in my opinion. And it really the title really gets at the glory of the human condition and the interactions that we have with each other in relationship when we have real, deep, true communication, and that every deep drawn breath is sweet, and that the air in the room is sweet when we have these sorts of real, true, unhindered communication with another person. And unfortunately, in many times in our lives as people, we don't have such unbridled communication. Things get interrupted, and in medicine that happens a lot. And I think that it causes a form of injustice, which I call testimonial injustice. It's a form of silencing of the other. And this happened with Teresa, because when Teresa was my patient, she was kept deeply sedated and immobilized by me. And I, at the time, thought that it was the right way to care for her, Nicholas. But I'm going to read to you what the interaction was like after I thought I'd done this great job. Oh, I'm such a good doctor. And then she and her mother come back to the clinic. And so this is from page 9 in Every Deep Drawn Breath. Almost immediately, Teresa's mom asked, why can't she bend her elbows at the arms? Why can't she move her arms at the elbows or move her shoulders? Her mom looked drained, more tired even than when she visited her daughter in the hospital. We ran through a litany of other problems that Teresa was having. She couldn't swallow properly or sleep or go to the bathroom alone. She couldn't shower or dress herself. She could walk only a few steps at a time, and stairs were impossible. The idea of returning to her old job as an administrative assistant was impossible. The list of ailments was dizzying. I had no immediate solution for any of it, and even less understanding of where the problems were coming from. So I did what I knew how to do. I ordered blood work and x-rays. The labs didn't show anything alarming, but the x-ray images of her arms and legs revealed large calcium deposits in her elbows, shoulders, and knees. Teresa had heterotopic ossification, a condition in which bone develops where it shouldn't due to extreme inflammation and prolonged immobilization. It was as if she had rocks growing inside of her joints. I'd never seen anything like it before and didn't know what to think. Teresa didn't react at all when I showed her the disturbing images, but her mother nodded in affirmation, as if she now had permission to talk about other concerns. She told me that Teresa's brain wasn't working properly, that she would forget things, people's names. that she had grown afraid. Miss Martin stopped and shifted in her seat. She's a completely different person now. She glanced at her daughter, sitting next to her in a wheelchair, and sighed. After Teresa and her mother left, and this gets, Nicholas, at what you asked, how did I feel as a young physician? And I carried this with me for a long time. After Teresa and her mother left, I sat in the room alone, my door closed against the world. Until usually when I finished with a patient, I'd ask for the next one right away. Not this time. Earlier that morning, I'd seen the name Teresa Martin on my list of scheduled patients and imagined a triumphant reunion, a cheerful, "You've given me a whole new lease on life." At the very least, a smile. I thought she would have been back at work by now, laughing with her friends, enjoying life after a close brush with death. Instead, she was a broken young woman in a wheelchair whose life now was much worse than the one she'd lived just a few months ago before coming under my care. What if she never walked again? What if her brain was permanently injured? In my gut, I knew that something about her care that she had received in the ICU had damaged Teresa. She'd come in with failing organs and we'd fix them, but somehow she had acquired a completely different set of ailments, new trauma to her body and brain. I thought I'd found my calling, pulling patients back from the maw of death, but now I wasn't so sure. I started wondering if saving lives was also causing harm. And the reason I chose to read that to you, Nicholas, and to the listeners, is that we have to recognize that in this time of the pandemic, that this is happening to millions and millions of COVID survivors who are coming in, getting care, and leaving with this form of brain and body injury. And that's even before the 100-day delay of the onset of what we all know now as long COVID. So they get this first problem, which we call post-intensive care syndrome, or PICS, P-I-C-S. And then 100 days later, the immune system kicks in a form of pathology and creates also additionally long COVID. So they have these two major problems that these people are suffering from. And the least that we can do is try and organize the first part of care to create less injury and less PICS. What are you wondering then, Nicholas?
And PICS, like, what's the medical definition then of what PICS is? Like, what are the?
Yeah, so PICS is the condition of millions of survivors of critical illness or hospitalization generally, whereby somebody leaves the hospital with these new problems: neck up, brain dysfunction that manifests as a dementia, which looks a lot like Alzheimer's disease. In addition, post-traumatic stress disorder and also depression. And then neck down, muscle and nerve disease that prevents them from being able to walk up a couple of stairs or do their old job, care for their house, etc. So PICS is acquired dementia, PTSD, depression, and muscle and nerve disease that creates an overall body disability that stops people from going back to work and being the person that they were before.
Right, and PICS is actually quite a new concept, right? That it's something that physicians didn't recognize until quite recently.
So to put that in perspective, so Teresa Martin was my index patient with PICS, and that was 1989, 1990. We didn't call it PICS until 22 years later, until 2012, when we came up with the definition of PICS. So the term PICS has been around almost a decade, and we know that this occurs, frequencies are important. This occurs in probably 1/3 to 1/2 of people who leave intensive care. And it probably occurs in about 15-20% of people who just have a regular hospitalization and never even land in the ICU. They leave with these same ailments.
So looking back, Teresa was actually your first patient with PICS, right?
She was my index patient, and she's the one who set me on a new course of research that I've been following now for 30 years and spent most of my life doing. This is NIH funded research. This is federally funded and VA funded research where we have enrolled thousands and thousands and thousands of patients into our investigation. So this is not warm and fuzzy, it's hard science. And we know the things that are occurring. We actually follow these patients years later, and we do neurocognitive testing. We have documented in the New England Journal of Medicine, JAMA, and Lancet all of these all these studies, and our website, by the way, for the listener, is just icudelirium.org. So icudelirium.org. And on that website, you can find tons of stuff for patients and families as well.
Right. And, we talked about PICS, but then there's also PICS H.
PICS F.
Sorry, PICS F, F for families. Tell us a little bit about how PICS can really affect families and people's social relationships, and what is PICS F?
Yeah, good. I'm glad you asked that. PICS F is when the family members develop PTSD and depression themselves. And I'm going to read you a paragraph. We hadn't planned this one, but this is so here's a young boy named Titus, goes in the hospital, has sepsis. COVID is a form of sepsis, by the way. Sepsis just means that you're infected with something, a virus, a bacteria, and the rest of your organs go, start having problems. So that's what sepsis is. And this boy Titus had sepsis. His mother and father's actually a rocket scientist in Alabama, and they take him home. They finally get him to survive, and he goes home. And then here is the paragraph describing their arrival back home. Even with the best treatments in the ICU, recovery is still difficult. Post-ICU interventions are a crucial part of the ongoing care plan. It's been a year now since Titus went home. He's back in school, back to being a kid who loves trying out Jedi moves with his new lightsaber. But the ordeal of his hospital stay is far behind him, or is far from behind him or the rest of the family. Sorry for my poor reading. Titus still struggles with ongoing weakness and pain in his feet, legs, and arms. He has nightmares about bandage changes and blood draws. His panics occur when he has rough play and he's afraid that he may be hurt again. His sister Caroline worries about him constantly, always needing to know where he is, and has developed a chronic phantom foot pain of her own. Wiley, the brother, has become protective of his little brother and is concerned about his parents dying. Both Allison and Matt have been diagnosed with PTSD, and the stress has caused Allison's Crohn's disease to flare up, leading to multiple hospitalizations in short order, adding to the children's anxiety. As Allison puts it, there's just a whole lot of layers to our onion. So in that example, the whole family has been affected by this problem. And Teresa Martin's son, whom I reconnected with in writing the book, he had a very difficult childhood. His name is Travis. All the people's names and stories in this book are totally true. Travis told us that he had no childhood because he was constantly getting his mother in and out of wheelchairs and into the house, having problems. Her memory problems created problems for him, and he had to make up for her deficits. And, this PICS F is something that makes people have to stay out of work. They can't go to work because they have to stay on with a family member. And then the family loses their sources of income. They oftentimes lose the electricity, lose their house, end up on the street, get divorced. So it's something that really permeates society much more deeply than people might generally think.
Right. And now taking like a more broader view now, throughout the book, you mentioned that, critical illness has lost its way from its hopeful beginnings, right? What do you mean by that critical care has lost its way, and how is that related to what we now know as PICS and patients?
Well, I guess, Nicholas, what I would mean is that the idea 30, 40 years ago that we would keep people alive who get as sick as COVID patients was not really a reality. We didn't have the technology to do that. But over the years, our technology has developed to the point that we can keep people alive who would otherwise have been dead and in the ground. And so when you shift people from the dead column over into the living column, you think you're always doing a good thing by shifting them into that living column. But with PICS, the truth is that if we don't pay attention to their survivorship, that we may not have, there are prices bigger to pay than death sometimes. And I'm not trying to downplay the value of a human being. And I certainly don't want the listener to think that I think that disease diminishes the value of a person, because it doesn't. No manner of disease reduces the pricelessness of a human being. However, the immense amount of disease that people accrue with all this technology can really mess up their quality of life. And when I say that critical care lost its way, what I mean is that we need to acknowledge that the technology in the ICU is not the end of our job. My job has to extend out into the months and years after the ICU survival, or else I've really abandoned my patient, and I have acquiesced into a line of thinking that I do not think is true healing as a physician.
Right. Yeah, and you mentioned in the book, right, is that, ICU doctors have long focused on, survival and using that as a benchmark of success, right? But there's so much more to survival, like the quality of life for patients after they leave the hospital, right?
Exactly.
Much more to it.
Exactly. And we need to acknowledge that when a family member is leaving with their loved one who just survived, and that family member is feeling guilty and scared and depressed, that's a common problem we call PICS, but that they're not crazy and they shouldn't be made to feel guilty for that. And they should be given therapy themselves, and it should be validated in their experience. The patients are the experts of their own illness. And during COVID long haulers have been silenced. They've been given the silent treatment, and the silent treatment, and the reason they've been given the silent treatment is that doctors are kind of often afraid to say, I don't know. So when we don't know something, and there's a lot we don't know about long COVID, we kind of pretend to order more tests, and we don't communicate to the patients this message, which is, I don't know what you're going through. You're the expert of your illness. I want to validate that what you're going through is true and real, even if I don't understand it. And I'm not going to abandon you. I'm going to stay with you, and I will help provide some form of approach to your life to help you pick up the pieces, even when right now I'm telling you I'm not sure what that's going to look like. I'm not going to leave you.
Right, really acknowledging what patients are feeling, right? Even if they don't fully understand.
Yes,
that's very important, right? And in the book, you also talk about this culture of deep sedation and immobilization that's in the culture of ICU care. Can you tell us a little bit more about this culture and how it can unintentionally actually harm patients, and how you came to realize that it could actually harm patients?
Yeah, in a tool in Abraham Verghesi's book Cutting for Stone, there's a line that I use as the quote to begin one of the chapters in Every Deep Drawn Breath, which says that the patient had scuba gear shoved down their throat and felt like they were at the bottom of the ocean. And I've used that analogy for years about the ICU, because when we put the ET tube or the endotracheal tube down somebody's throat to put them on a ventilator, and then we sedate them, it's as if we're submerging them in water deeply, 10, 15, 20 feet down. But sometimes we submerge them so deeply that they're 100 feet down, and they're essentially depersonalized in the ICU. And to use technology in that way should be very, very vanishingly short in time. To do it at the very beginning of somebody's critical illness, I often have to do that, but I want to keep that period as short as possible. And what happened in COVID, and what happened back in the 1990s before we undid it prior to COVID, was that we kept people like that for days and weeks. So Teresa Martin was kept deep down 100 feet below the water for days and weeks, and it created this problem that I read to you earlier. Well, from 2002 to 2018, we studied this and proved a better way forward, which is called the safety checklist of the A2F bundle. The letter A, number 2, letter F bundle. And the A2F bundle stands for the A, B, C, D, E, Fs. And that's 6 steps that we take in the ICU, which if you or your loved one comes in the ICU, you could say to your doctors, are you using the A2F bundle? Are you complying with this? Because I want you to, every day, wake my loved one up, get them out of the bed, get me as a family member next to them in the hospital. The F, for example, is family, to get them at the bed, get them next to the bed. And we know that we abandoned family at the beginning of the pandemic because we were afraid of the infectivity of the virus. And that did a lot of harm to people. How many people died because they lost hope or lost sight of their own selves and their life when no one that they loved was allowed to be with them for days and weeks? I believe that people can die of a broken heart. And so the bundle, the A2F bundle, is a way to resurrect humanism in medicine and help us to do things better in a systematic fashion. And in every deep drawn breath, I tell lots of stories about how we got off track and how we found our way. And in around 2018, 2019, we were complying with the bundle in the 80% range all across the country and the world. And now we have documented that in COVID, we're in the 10 to 20% range of compliance. So it's just been completely undone, and we have to find our way back.
Right. Do you think because of COVID, like all the novelty of COVID and just like the number of patients that like doctors just, abandoned best practices in some ways and reverted back to old practices?
I think that that's what happened. There's a place in the book where a doctor told me from New Orleans at the middle of the surge, where his name is Dr. Hollis O'Neill, and he said, we have abandoned all that we learned in the past 15 years during this surge. And he said, I am done with that. I'm going back to what I know works. And he started building the bundle back into his daily life in the ICU. And a few months later, he sent out a picture of a COVID patient on a ventilator on 100% FiO2, holding up a sign to her family that said, get vaxxed. And so this woman was not in a coma. She was wide awake on 100% oxygen on the ventilator. And she's holding up this sign that says, go get vaxxed. That's humanism. That's looking her in the eyes and saying to her, not what's the matter with you, but changing the preposition to what matters to you. And what mattered to her was to get her family to go get the vaccination so they didn't end up in the hospital sick like her. That's real communication. That's the way it needs to be. And I love that example.
Right. And in the book, you also talked about you visited a hospital in Denmark where you really saw this humanism in critical care. They had this quote, like no sedation policy, or more like very light sedation policy, right? And that was quite like counterintuitive for you at that point, like or even for a lot of other physicians. Can you like tell us about what that experience was like for you, and like what were some of your main takeaways from that visit to the hospital in Denmark?
Yeah, this doctor named Thomas Strom had published this paper in Lancet. The three biggest journals are Lancet, New England Journal, and JAMA. So whenever you publish in one of those three, it's good. And by the way, the bundle, the A2F bundle, is founded on almost 40 Lancet, New England Journal, and JAMA papers. So very high science. One of those papers was this article by Thomas Strom, and he invited me over to help defend his PhD thesis. And so the chapter begins, I was standing in front of a daffodil yellow cottage. I'll never forget that day that I was in front of the cottage where Hans Christian Andersen grew up and wrote his famous, children's stories and fairy tales. And one of them was The Emperor Has No Clothes. And I thought that the emperor had no clothes in Denmark, that they were faking it, that it wouldn't be true, it wouldn't be real. And what I found out was that every patient in their ICUs was awake and alert and communicating and talking about what mattered to them. And I left that experience just thinking, oh my gosh, this is possible. How am I going to do this in the United States? And what data can I generate to make people realize that this is the way that's better? And what it essentially does is take, all this technology that keeps people alive can supplant the beauty of human touch. If you put technology in front of human touch, then you will rearrange critical care so that the machines and the buzzers are more important than the person. And so what I try to do with every deep drawn breath and the patient stories in the book is to help all of us realize we need to flip it back around again to find truth and beauty of touch first and technology second, and not the other way around.
Right. Yeah. And you talked about therapies like music therapy or even ICU diaries that families and the medical team can keep, right? Those are just some examples of like the human touch That's
Yeah, absolutely. Music is, people come into the ICU with their own color and tastes of food and loves of different types of music. And for me to take that person and drive them through a depersonalization chamber so that they are in gray tones rather than vivid color is wrong. And yet for years, I did that. And I carried a lot of shame and guilt around in my life as a human being because I felt that I was doing the wrong thing, but I didn't know how to get out of it. And what we now do instead is we wake them up every day, we get them out of the bed, we walk them, and then we play music on the bed itself or on headphones, and we give them, access to the things that make them a unique individual human being. A lot of times it's spiritual values. One time I had a woman come in the hospital, and this.
Sorry, you lost your. I think you're on mute.
Yep.
Yeah.
I don't know how that happened. Anyway, we had a woman come in. I was saying that sometimes what makes them unique and makes them feel whole again is to address their spiritual values. And one time a woman came in and she said, Dr. Ely, I am an atheist. I do not believe in the afterlife. And but I'm dying, and she had cancer, and she had a big surgical abdominal incision. She had a lot of pain, but she said, I don't want to be snowed out because I want to talk to my family members. And in the book, I tell the story that she asks each family member 3 times, do you love me? And they would say back, yes, you know that I love you. And she said, well, give me a hug and tell me, do you love me? And then a 3rd time, do you love me? And the answers and the communication between these family members and her were so beautiful and so deep and so rich that I was just in the corner with tears welling up in my eyes. And so to allow her that spiritual process, even though she was a completely a-religious person, was everything for me as a physician to make happen. And I want to do that for all of my patients. I want to honor who they are, where they are, and what they need during that critical period of time for them. And the only way I know how to do it is to pay attention to the entire human person and not just their lungs or their heart.
Right. Like to see the person beyond the disease, right? To see the whole person. That's always very important. And so what is really happening then in patient's brain when they are in the ICU and they're being deeply sedated with drugs like benzodiazepine and things like that? Like what's really happening in their brain?
Let me tell the listener by way of a true story rather than me just paraphrasing. So I'm going to tell you 2 stories. This is a conglomerate from the chapter called Delirium Disaster. I heard one patient describe an attack by a mob of green aliens. Another recounted a story about being swarmed by snakes. And yet another said he was constantly being pushed down a long, dark tunnel. I listened to story after story with a sense of growing comprehension and alarm. We had thought our ventilated patients were sleeping, protected by sedatives, paralytics, and pain medicine from the intense discomfort caused by life support machines. But clearly, they were not serenely dreaming. They were delirious, afraid, and confused. When family members turned to me looking for help and how to respond, I was unsure. Should they dismiss the stories and say that they weren't real? Or should they acknowledge them, suggesting they were hallucinations and delusions? Neither response seemed especially reassuring to the patient. I started to think about these stories all the time. And then I'm going to skip a couple of pages and tell you about one specific patient. His name is Kyle Mullican. Kyle nodded. He seemed eager to share. Well, everything was in vivid color. So I'm on a ventilator and I woke up and my wife, Katie, was sitting next to me trying to tell me what's going on. I looked over my shoulder, just glanced up to the right, and my monitor was there. But behind it, I saw a black jaguar perched up in the corner in pounce position, moving its tail real slow. I remembered getting upset. Katie thought it was about the monitor being hooked up and said, "It's okay, Kyle, it's helping you breathe." But I was thinking, there's an apex predator in the corner. Are we really going to pretend this cat isn't about to pounce on us and tear us all apart? He paused for a moment. I was convinced that if I took my eyes off it, then this thing was going to kill us all. My hand was restrained, so I couldn't even defend myself. That went on for about a full day, and everyone thought I was looking at the monitor. And that was upsetting because I was thinking, I'm not the crazy here. You guys don't see this thing? So in a way, you might laugh and say, I'm not the crazy here. You guys don't see this thing, and think that's funny. But to Kyle, it's so real. And the truth of this is that he still has this dream now, years later. Another patient was forced to play a game every night where there were 3 people in front of him with bags over their heads, and he had the flu, and he was on the ventilator, and he was forced to shoot one person. And every time he'd switch the person, because when they pull the bag off, it would be his daughter. So now 10 years later, he's still having that dream every night, and he's afraid to go to sleep. And they all say this: it's more real than real. It's not a dream to me. It's actually happening. And I don't understand that because I've never been delirious before, but they all say that. And it just must be absolutely terrifying.
Right. Like to them, it's completely real. Like it doesn't.
Exactly.
Got it. And yeah, Dr. Ely, let's talk a little bit more about like the connection then between like, ICU survivors and the link between, cognitive impairment and dementia then, because, in the brain ICU study that you and your team, I think, so it stands for bringing to light the risk factors and incidents of neuropsychological dysfunction, right? The brain, that's what it stands for. And
yeah. In that study, we studied hundreds of patients, 800 actually. And we proved for the first time that delirium is a predictor of the development of the dementia. So nobody really knew that in the ICU. They thought, how could you get dementia after a few weeks when dementia is something that should come on in years? But we all felt like it was being zipped up and happening like in extra fast time. And that is what we proved. And there's a patient in the book named Sarah Beth Miller. There's lots of people in the book with this problem, but Sarah Beth is a particularly poignant one, because just like Teresa Martin was my index patient for PICS, Sarah Beth became the index patient where we actually had someone, and this is how this went down. One day she came in and she said, I'm an engineer, I'm a mathematician, I am just kicking butt in life. I get sick in my early 50s, and now I'm having to retire early. I can't go back to work. Why not, Sarah Beth? Well, because I can't think well. Wait a minute, what do you mean? Well, I just don't, my brain doesn't work. So we tested her and we told her, Sarah Beth, we got your test back and your IQ is about, it's okay. It's 110 to 115. And Sarah Beth just freaks out and says, what? My IQ is 110, 115? She goes, it's always been 140. And we said, wait a minute, what? You've had IQ testing before? And she said, yes, I've had IQ testing multiple times. So she was the first person that we ever met that got emergently ill in the ICU with a disease like COVID. She had ARDS, which stands for acute respiratory distress syndrome. It's when your lungs fail. It's what all the COVID patients are getting and why they're on the ventilator. And anyway, she was the first one that had it, that got the brain problem afterwards. And beforehand, we knew that her brain was near genius level. And so I'm going to read to you what happened when we got the MRI, because what happened was we wanted to image her head and figure it out. But after she got out, she was so depressed about her life that she got braces on her teeth because she was like, I got to have something to lift me up here. So she gets braces, and we had to wait for a couple of years because you can't put somebody in the MRI if they have metal on their teeth. So when she finally gets her braces off, here's what happened. I soon had the results in hand, and what I saw was devastating. Her previous scan had not shown any signs of brain atrophy because she had gotten imaged when she was in the hospital. Had shown no signs of brain atrophy, loss of brain tissue. But this new imaging, according to the neuroradiologist, looked like the MRI of a demented 85-year-old. Sarah Beth was 52. As anyone who observes a drawing of a brain quickly notices, the outside has a wrinkled appearance made up of bumps and grooves. These are called gyri and sulci. And on the interior spaces called ventricles are filled with cerebrospinal fluid. This fluid comes down from the inside of the brain into the spinal canal. And it's what doctors drain with a needle when we do a spinal tap to look for meningitis or a bleed. Since the skull encases all of this fixed amount of space, our heads are filled with varying amounts of brain tissue and fluid. As I stared at Sarah Beth's latest MRI, I saw immediately that she had lost a huge amount of actual tissue. The sulci were much deeper, and the ventricles filled with fluid were larger, having grown to fill the void left by the disappearing brain tissue. Millions of brain cells were missing. It was as if tons of rich soil had been removed from a garden, leaving behind puddles of muddy water and a few wilted perennials. 2 areas of her brain showed especially significant degeneration: the hippocampus and the frontal lobes, regions that specialize in memory and executive function. This made sense. She told us about her forgetfulness and her inability to organize her life. It was sickening to look at, yet I couldn't pull my eyes away. I saw the scan of Sarah Beth's badly damaged brain as a map of her muddled and tangled thinking, visible confirmation of an invisible disease. I mean, I don't know how to say it better than that. Imagine that, though, playing out for millions of people all over the world. And now what you've got is a driving unmet need to acknowledge that we have a major public health problem on our hands that society is not yet equipped to deal with. And we have to think, how can I better understand a person who's suffering in this way so that I can meet them where they are and help them and provide mercy?
So how do physicians, say like a patient like Sarah, how do physicians, help her and treat what's happening to her brain then?
Yeah, what we're finding is that even months or years later, we can get cognitive rehabilitation for Sarah. So Sarah Beth, let me paint this picture for the listener. So let's say that I get bonked on the head with a car wreck. I will have a macro form of injury in my brain, and on a CT scan, you'd see a big stroke or a bleed in my head. That's macro injury. What Sarah Beth has is micro injury, meaning that all over her whole head, she's got millions of lost neurons. But if I was to look at her MRI, at first it would look normal, and then years later, it would still look generalized normal, except it would have atrophy like Sarah Beth's did. What do we do for that? We give her exercises like Sudoku and Scrabble, brain exercises that actually work her brain like you would work your bicep, like you would lift weights and do curls to build that bicep back. If I'd put your arm in a cast after it was broken, and then I took the arm out of the cast 12 weeks later, and your arm was all shriveled up, you'd go back to the gym and start rehabbing your arm. Well, we need to rehab the brain the same way. Does that make sense?
Leveraging the brain's neuroplasticity, right?
Absolutely. And the brain is so neuroplastic. It's absolutely beautiful. There's a whole section of the book. I won't read it, but there's some beautiful stuff in the book about neuroplasticity. And we've partnered now with some neuroscientists, Adam Ghazali, Michael Merzenich, and others. And I actually met the Dalai Lama over this because the Dalai Lama is very interested in brain science as well. And we are now doing studies where we put people, ICU and COVID survivors, through 12 weeks of cognitive rehab, and we're getting their brains back. It's absolutely very exciting.
Right. So people are actually like, it has the potential to help people recover from their cognitive symptoms, right?
It absolutely does. So I kind of view this as my life goal now is that all of us realize that we can do 2 things big time. One is that when people are sick and in the hospital or the ICU, that we can use the A2F bundle to humanize the care and to reduce the delirium duration, because the A2F bundle reduces death, reduces delirium and coma, reduces ICU bounce backs, reduces nursing home transfers, and all that stuff. So if we use the A2F bundle with high compliance, and you all should push for this for your loved ones when they're in there, and that will reduce the problem, but it won't eliminate it. And then on the back end of this, whatever problem we're left with, we can help them rebuild their brain and body by great rehabilitation programs.
Right. And what's the evidence of like delirium, cognitive impairment, and dementia then, like in terms of how does
the evidence. So the evidence is that we published this in the New England Journal of Medicine, and others have followed this up with consistent similar findings. For every additional day that somebody is delirious, that is just confused, just think unable to pay attention. So during sickness, when somebody's unable to pay attention, that's delirium. And inattention is the biggest factor, not the hallucinations or delusions. So every day that somebody is inattentive or delirious during illness, that creates a 10% increased risk of death and a 35% increased risk of long-term brain dysfunction. So if you do the math on that, 3 days of delirium and you've got a 1/3 likelihood increase of dying and almost 100% chance of some long-term brain dysfunction that needs rehab.
Got it. Got it. And how does delirium play into PICS then? Is delirium like a symptom of PICS? Like how do we think of it in terms of
So delirium is the your eye color is a phenotype. Eye color is a phenotype. So it's the outward expression of something. So delirium is the outward expression of the brain failing and having these dying neurons during the illness. And then that's the phenotype of the brain failing in the ICU. And then the long-term manifestation of that is that if you lose all these neurons in the ICU or in the hospital, the long-term manifestation of that is going to be difficulties with memory and executive function, just like Sarah Beth had.
Got it. All right. And Dr. Ely, my last question here then, do you have any like overarching advice in terms of for families or patients at the ICU in terms of what are some good questions to ask doctors in terms of like reducing their likelihood of developing PICS or PICS, H or delirium?
Yeah, sure. And by the way, I like to give people resources. So on our website, there are lots of links to articles that I've written, like for the Washington Post or other like Stat News. I just wrote one in Stat News on silencing of long COVID. And there's one that directly answers your question just now. It's in the Daily Beast. So if you just Googled Wes Ely, the Daily Beast, you find one that says, what do you need to know about your next ICU stay? And I wrote that 800-word piece just about a month ago. And it really tells the family members and the loved ones, what is it that I need to be doing when somebody's sick in the ICU? But the bottom line is that you need to be saying, you know what? I need to be there, first of all, so I can advocate for them. So don't give me a no hospital visitation policy, because that's anti-medicine and it's inhumane. And I'm not a luxury. I'm part of their treatment plan. So I think people need to speak up, and any hospitals that still have a no hospital visitation policy have to be called to the mat on that, because it's wrong. And you don't have to, because PPE works. So we can safely set up hospital visitation. Second is, when you're there with your loved one advocating for them, you should say, are you monitoring for delirium? And does my loved one have delirium today? And I'll leave you with this last thought, if they do have delirium and you notice that they can't pay attention and they're not following your commands or your questions, then you need to invoke what I call the Dr. Dre. And the Dr. Dre, he's the famous rapper, the earbud guy. This is all over. You can find this on our website, icudelirium.org. And by the way, I'm on Twitter at Wes Ely MD. So if you just look me up on at Twitter at Wes Ely MD, I'll be happy to communicate with you. But the Dr. Dre stands for, these are the causes, these are the ways to address delirium: diseases, drug removal, and environment. So DDRE, diseases, drug removal, environment. So if somebody's delirious, you think, what are the diseases causing it? Like COVID, sepsis, emphysema. What are the drugs to be removed? So antibiotics that are no longer necessary. Anti-ulcer medicine is no longer necessary. Sedation, which has been on for too long, get rid of it. Drug removal. And environment is huge. Environment, these are non-pharmacological ways to cut delirium in half. And the two biggest ones are getting somebody out of bed and having the family member at the bedside, by far. And that's the E and the F of the A, B, C, D, E, F bundle. E is early mobility and F is family. So just by doing those last two steps, early mobility and family, you cut delirium in half. Thanks, Nicholas.
Thank you, Dr. Ely. And for our audience, if you've missed any of this interview or would like to hear more about our upcoming live talks, don't forget to sign up for our newsletter at beingpatient.com. Thanks for watching. And thank you, Dr. Ely. Bye.
Thank you. My privilege. Everybody have a great day.